Hello, this is Kimberly Knapp. This is my physical exam for Nursing 502, my complete head-to-toe exam. As I begin the exam, I'm going to be looking at my patient's overall appearance, just how they look in general, whether or not they look well nourished, their overall stature, posture on the table. I'm observing the affect on his face, whether or not he looks engaged as I'm speaking to him. And then if the patient had ambulated into the room, at that point I would be observing his gait, noting whether it was steady or unsteady. Also I can see he appears to be well groomed. He's got no distinct odors. He is breathing regularly, and he appears alert. So I'm going to go ahead and introduce myself. Hi, my name is Kim. I'm a nurse practitioner student doing your physical exam today. Can you tell me your name?
My name is Andrew Knapp.
Okay, Andrew, can you please tell me your date of birth?
6/24/88.
So the patient is able to tell me his name and his date of birth, proving that he's coherent and alert, able to respond appropriately. So I'd be making note of that for his neurological status. At this point, I'd be looking through his chart, seeing that he had his vitals, his height and weight, and his Snellen eye exam done before I came into the room. So I'd be looking through that, noting that his blood pressure, heart rate, respiratory rate, oxygen saturation, and temperature were all within normal limits. His height and his weight are normal for his age. And then his Snellen eye exam, which shows his visual acuity, showed that his vision is 20/20. So I'll make note of that for when I do my cranial nerve assessment for cranial nerve 2, the optic nerve. So then we're going to begin our physical exam. Looking at the patient's skin, right now, based on his attire, I am able to visualize a lot of his skin, but you kind of incorporate skin into your head-to-toe assessment as you're going down your system. So I will be remarking about skin as I go through my exam. So I'm going to start with the patient's head, ears, eyes, nose, throat, and neck. So we always start head to toe, distal to proximal. So we're going to start with the patient's head. I'm just going to look at his overall skull and shape of his head. It is round. I don't see any obvious deformities, no masses or gross abnormalities that jump out at me right away. So I'm also observing his ears, his eyes, his nose, and his mouth, making note that everything on his face is symmetric bilaterally. His ear, the top of his ear is in line with the outer canthus of his eyes, and they are symmetric on both sides. The ear including the pinna, the auricle, and the tragus. He's looking at me, acknowledging that he can hear me speaking, and showing that his auditory nerve is intact. He's able to make eye contact with me as I'm speaking to him, which also shows that he's alert and his vision is intact. His eyes, he's looking at me directly. I can see that they are in line with his nose, which is midline, along with his mouth. I'm looking at his skin. It's warm, it's pink, it's dry, no diaphoresis or perspiration noted. So then I'm going to, after I inspect and look at everything, I'm going to start to feel and palpate, beginning with his eyes, I guess beginning with his head rather. We're going to feel the skull, palpating all the bones of the skull and the face, and noting any tenderness that the patient might complain of. Also at this time we're going to palpate the sinuses, noting any tenderness. And if the patient did have tenderness in his sinuses, we could then transilluminate the sinuses with a light shining here and here in the downward direction, seeing if there's any drainage within them. And like I said, with skin, I don't see any obvious lesions. An important place to check is always behind the ears. That can be a common source of carcinoma of the skin that can easily be missed, so that's something I would want to pay attention to. So everything looks symmetric, looks normal so far. So now we're going to begin with the eyes. So with your eyes, like I said, I'm looking at them, making my observations. He's got two eyes bilaterally. They are symmetric on both sides to the midline. His conjunctiva, his sclera are white. His irises are brown. His pupils are dark black in the center. I'm going to look at his sclera. If you can look up to the ceiling, Andrew. They are nice and pink. His lacrimal ducts have no visible obstructions, which means he'd be able to produce tears. His eyelashes are pointing upward, and they look nice and full and soft. Also at this time I could do the corneal reflex of his eye, which would entail using a cotton ball to test. You would lightly touch the patient's sclera as they look in the opposite direction to test and see if you get that blink response, showing that that cranial nerve would be intact. So once you look and observe everything, you will start with a physical exam. So first, I'm going to shine a light into his eyes. So Andrew, if you can cover your left eye for me. I'm going to shine my light into this eye. If you can just look straight ahead into the camera. And his pupil went from a size 3 to a size 2, which is a normal finding. And we'll do the same with this eye. And again, equally constricted from a 3 to a 2. And now we'll do both eyes together. And the patient's pupils are equal round reactive to light and accommodation, which is a normal finding. Also at this time we can check optic nerve 2, or excuse me, cranial nerve 2, the optic nerve, which I said we tested his acuity with the Snellen exam prior to my physical exam. Now we'll test his peripheral visual fields. So Andrew, if you can just look straight ahead, I'm going to wiggle my fingers around your head, and I want you to tell me when you see them, okay?
Stop. 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 Stop.
Okay. So he was able to see my fingers wiggle in all fields of vision, showing that his peripheral vision is intact. Cranial nerve 2 is intact. Also this time I can test some other cranial nerves, more specifically 3, 4, and 6, the oculomotor, trochlear, and abducens nerves. And with this, you're going to use a pen. So Andrew, once again, look straight ahead, and you'll see my pen now. And you're going to follow the tip of my pen with your eyes. Don't move your head, okay? So he was able to move his eyes in all directions, showing that these 3 cranial nerves are intact. And then his convergence was intact as well when I went in towards the center. Lastly, with the eye exam, you're going to do the fundoscopic exam, which you should darken the room for. I'm going to try to darken the room and see how dark. So with this, with the room darkened, you're able to see the fundus of the eye better. So we're going to look in each eye. And I'm able to visualize the red light reflex as well as the vessels in the back of his eye. I don't see any edema or abnormalities there. And then lastly, since we're testing some cranial nerves, I would just go ahead and finish the main cranial nerves that are involved in these systems. So we're going to do cranial nerves 5 and 7, which is trigeminal and facial. So Andrew, if you can just look at me and follow what I'm doing as I say it, okay? So can you clench your teeth? Squeeze your eyes tightly shut and try to resist my opening. Very good. Wrinkle your forehead. Raise your eyebrows. Smile. Frown. Stick out your tongue and pop out your cheeks. And then we're going to test your sensation, which once again is cranial nerve 5, trigeminal. So this is testing dull and sharp sensations of the patient's face. You're going to do the forehead, cheeks, and chin. So Andrew, I'm going to ask you to shut your eyes, and I'm going to be touching your face. I want you to point to where I'm touching, as well as tell me if it is sharp or dull. Do you understand?
Yes. Dull. Sharp. Sharp. Dull. Sharp. Dull.
Okay. So the patient was able to tell me where I touched him, as well as the sensations that he felt, meaning that that cranial nerve is intact. So after eyes, we're going to move on to the ears. So we kind of already inspected them a little bit, but once again, we're looking at the outer part of the ear that we can visualize. His auricle pinna tragus are pink, they are warm, they are intact, no abnormalities. Is there any tenderness when I press? Tragus, mastoid process can be indicative of an ear infection, so you would note that. So no pain there. And after we inspect the outside, we're going to look on the inside with my otoscope. So for an adult, you're going to pull the pinna up and out. Looking in his canal, it is pink, very minimal cerumen. I'm going to look on this side. Same on this side, a little bit of hair, but the canal is pink. I'm also able to visualize his tympanic membrane. I see they are both gray and pearly and shiny, which is a normal finding. I'm able to see that light reflex, and I don't see any bulging, any drainage or redness, which is all normal, good finding. Okay. Also with the ears, we're going to test for hearing. So for this exam, I'm just going to do the whisper test in each ear. If he were to have any difficulties with his hearing, I could also do the Weber and Rhine test, which tests for lateralization of hearing and bone and air density. And you would use a tuning fork for that. However, I don't have one, so we're just going to do the whisper test to see if his hearing is intact. So Andrew, I'm going to whisper a word in each ear. I want you to tell me what it is. Okay.
Yes. Butterfly.
That is correct.
Caterpillar.
Very good. So he was able to hear what I said, meaning his hearing is intact. And that is cranial nerve 8, I believe, which is auditory. Okay, so now we're going to move to the patient's nose. Looking at his nose, skin is warm, pink. His septum has no deviation. It's in line with his midline. Are you able to sniff? Any clogging on either side? No, he's claiming that it's patent. He's able to sniff. Now I'm going to look internally into his mucosa turbinate. So if you can just kind of look up. Okay, and then this one. And everything looks good. It's pink, minimal drainage, a little bit of hair, all normal finding. And now I'm going to look into your mouth at the oropharynx and your posterior pharynx. So if you can just open your mouth for me. So I'm looking, it's nice and moist and pink. I'm looking at his tongue, his uvula, its midline. Can you stick out your tongue? Say ah.
Ah.
His uvula raised with the ah sound, meaning that cranial nerve 9 and 10 are intact. Also with that you could test the gag reflex using a tongue blade or whatever you choose, but for the sake of this exam we're going to not do that. Can you stick out your tongue for me? Okay, move it side to side. Okay, and lift your tongue up. So I'm looking at all sides of his tongue, his teeth, looking for any skin or abnormalities of any of that, and that all looks pink and healthy. I don't see any abnormalities or lesions. And by him being able to stick out his tongue and move it, that shows that cranial nerve 12, the hypoglossal nerve, is intact. His tonsils were +1s. I didn't see any exudate, just normal mucosa, moist and pink. Then we're going to move down to the patient's neck. So we're going to test his range of motion and resistance, testing cranial nerve 11, the spinal accessory nerve. Okay, so first, I'm just going to have you shrug your shoulders. So he's able to do that, showing that the nerve is intact. And then we're just going to do some range of motion with his neck. Alright, so his neck and his shoulder. So I'm going to have you move your neck side to side. Very good. Front to back. And then turn in a circle both ways. And he's able to do that. And then I'm going to have him do that against my resistance. So same side, side, front, and back. And then again with your shoulders up and down. Very good. So even with resistance, he has full range of motion. So I would give him a 5 out of 5 for his strength of that. Also with his neck, I'm looking at his trachea, noting that it's midline, no deviation. Looking at his skin all the time throughout the whole exam. It's warm, it's pink. And then with the neck exam, we're going to check for his thyroid. So Andrew, I'm going to place my fingers here at your thyroid. Can I have you swallow? Very good. So his thyroid has no edema. It feels normal. Also at this time we can palpate his lymph nodes for any enlargement or tenderness. So we're going to do preauricular, postauricular, cervical, anterior cervical, posterior cervical, submaxillary, and submental. And then your superficial clavicular. Sometimes if you hunch your shoulders a little bit and stick out your clavicle, yeah, you can feel them. And then the tonsillar. And I don't feel any lymph nodes on him. That's a normal finding, which is good. If you did feel any edema, that would warrant further attention. Okay, and then moving on. Also with the neck, we could palpate his carotid on both sides, one at a time. And then you could listen for bruits at this time, although my patient doesn't have a cardiac history, I'm still going to listen to it for the sake of this exam. And you might want to ask the patient to hold their breath. So I don't hear any bruits, that's a normal finding. Okay. So he doesn't have any tenderness, he has full range of motion, his skin is intact. So now we're going to move down to his upper extremities. Once again, looking first. So looking at his shoulders, he has 2 visible tattoos, which I would note in my skin exam. No other lesions. Any tenderness when I palpate your shoulders,
No.
your elbows,
No.
your wrists,
No.
and the joints of your fingers.
No.
Okay, so no tenderness, which is good. And we're going to do some, or actually we'll check his cap refill first. So checking each finger, less than 3 seconds, normal findings. Okay, so now we're going to do his range of motion. Okay, so beginning with your shoulders, I'm going to give you some directions and just follow my directions, okay?
Yes.
Can you raise your arms in front of you over your head? So that's testing flexion of his shoulders. Now can you raise your arms behind you? So he can fully extend his shoulders. Can you raise your arms out to the side and overhead? Here. Good. And can you cross your arm in front of your body? So that's testing abduction and adduction of his shoulders, which you can fully move. Also we can do rotation. Can you place one hand behind your back and touch your shoulder blade? And then can you raise your arm to your shoulder level, bend your elbow, and rotate your forearm towards the ceiling. Very good. So he can rotate internally and externally, which is great. So next we're going to move down to elbow. Okay. So for your elbow, can you bend your elbow? Can you straighten your elbow? So that's flexion and extension. You were able to do that. Can you turn your palms up as if carrying a bowl of soup? And can you turn them down? Very good. So he demonstrates supination and pronation of his wrists, or excuse me, his elbows. Next we're going to move down the arm distally to his wrist. With your palms down, point your fingers towards the floor. With palms down, point your fingers towards the ceiling. With palms down, bring your fingers toward the midline. With palms down, bring your fingers away from the midline, so like that. Okay. So he's able to flex, extend, adduct, and abduct. Adduction being for radial and abduction being for the ulnar. So you can fully do that. And then lastly, with his finger joints, I'm going to ask him to go like this and this. And any crepitus, noting, nothing, normal.
No.
Good. So he's got full range of motion with his upper extremities. I did just realize I forgot the joint of his jaw, so I'm just going to go back to the TMJ joint real quick and palpate that. So can you open up your mouth and shut? No clicking. He's good. Continuing on. Also, you could do all of the range of motion with resistance, and that is testing, the patient's musculoskeletal strength. So I'll just do a couple of those. Can you just move your arms out against my resistance? Okay. And then can you squeeze my hand? Okay. And then can you push upward and downward? Very good. And then we did the shoulder shrug. So he has good strength against my resistance. I've given him a 5 out of 5. Looking at him, he's got good muscle bulk and tone throughout his upper extremities. So I would make note of that. Hand grip straight, 5 out of 5. Also, we can test his sensory function at this time. So once again, if you can close your eyes, Andrew, I'm going to be touching you with objects, and I want you to just tell me if it's a sharp or dull sensation and point to where I touch you, okay?
Yes. Dull. Sharp. Dull. Sharp.
Okay. So once again, that's showing his sensory sensation is intact. Also, we can test his stereogenesis. If Andrew can shut your eyes, I'm going to place an object in your hand. I want you to tell me what it is.
Pen.
So the patient's able to identify a familiar object, showing that is intact. Also, this time you could test his vibratory sense using a tuning fork. You place it on the distal interphalangeal joint of patient's fingers and toes. However, we don't have a tuning fork, so we will forego that test. And then we can do his position sense, which I need you to shut your eyes, Andrew. And I'm just going to move your thumb in a certain direction. I want you to tell me if it's up or down, okay?
Down. Up.
Okay. So if you did that correctly, showing that his position sense is intact. Also, I can test his pulses and assess those at this time. So testing his radial pulses and brachial. And they're +2 palpable pulses, normal finding. And lastly, for the upper extremities, I'm going to do just palpate for his lymph nodes, the axillary and the epitrochlear. So if you can raise this arm. And palpate. Okay, can you put it down? And then this one. Palpating for any enlarged axillary lymph nodes. And then the epitrochlear are behind the elbow. Both sides. And I'm unable, excuse me, to palpate any of those lymph nodes. Normal finding. Okay. Next, we're going to move to the patient's back. First step in the SPECT, I'm looking at his back. Just going to pull your shirt up here. looking at his skin, looking for any rations, abnormalities, lesions. His skin is warm, dry, and pink, intact. I'm looking at his posture, his muscle bulk and tone. And then I'm palpating his spine and the paravertebral muscles. Any tenderness?
No.
So I would note if anything felt painful. Also at the back, you can check for costovertebral angle tenderness, for tenderness over the kidneys. This is located at the 12th rib and transverse process border. So I would find that and just palpate and ask the patient if he had tenderness, which could show an underlying kidney problem.
No.
Okay. And then after that, while we're back here, we're going to do his posterior chest and lungs. So first, I'm just watching him breathe normally, noting the depth, the rate, the rhythm of his breaths. They should be non-labored, regular, which they are. Also, I'd be listening for any audible wheezes, a cough, which would warrant further investigation. And then I'm going to palpate his back and then test for expansion of his chest cavity. So I'm going to place my hands bilaterally at the 10th rib and ask the patient to inhale deeply. Go ahead. Okay, and exhale. So with that, I'm just watching my hands move and his chest expanded symmetrically bilaterally. And then I did this already, but just palpating once again for all areas of the back, noting any tenderness. And after we feel, we can percuss bilaterally, side to side, starting up top, using my middle finger. And all the sounds that I heard were resonant, which shows healthy lungs. Also, we can test for tactile phremesis at this time. So I'm just going to have the patient say the word 99 down his back. Okay, can you say 99?
99.
Again?
99.
One more time.
99.
So I don't feel any tactile phremesis. You could also do the diaphragmatic excursion test while you're doing this. My patient is a healthy young male, not having any respiratory symptoms right now, so I don't believe it would warrant the test. However, if you were doing it, you would use the patient's right thigh and ask them to take a deep breath and exhale as you percuss down that right side, and you'd be feeling for an area from resonant to dull. Okay, so next, now that I've percussed, I'm going to auscultate your breath sounds bilaterally, side to side. You take a deep breath in and out. Deep breath in and out. In and out. In, out. In and out. In. One more. Lung sounds are clear. I don't hear any adventitious breath sounds. So I make note of that. Excuse me. Alright, so now we did the posterior chest and lungs. We're going to move to the anterior chest and lungs. Once again, inspecting his chest cavity, looking at his skin. He is warm, he's pink, dry, intact. Palpating the chest for any tenderness. Looking again, excuse me, Looking again at his breathing, noting that it's non-labored and regular. Also at this point, we can look for the point of maximal impulse for his heart, and you can also feel for this. So you're just going to place your hand. You can actually feel the PMI and note where you find that. And then once again, we palpated, now we're going to percuss from side to side, starting at the top. And once again, I heard resonant sounds when I percussed. And then we're going to listen for breath sounds, auscultate. Deep breath. Deep breath. Deep breath. Deep breath. One more. One more on this side. So once again, lung sounds are clear to auscultation bilaterally. Now we're going to move to the heart. So I'm going to auscultate for his heart sounds in 5 different places. The second intercostal space on the right is where the aortic heart sound can be heard. I'm going to start there. And then the second intercostal space on the left, you can hear pulmonic heart sound. And then for the right ventricle, you're going to move down to the left sternal border. The epigastric area. And then the left ventricle can be heard at the apex. And sometimes it's easier just to use the valve, so listen for this one. Sometimes if you're unable to hear, you can also ask the patient to turn towards his left to hear that last heart sound. And for him, I heard both S1 and S2. I didn't hear any murmurs. The rate and rhythm were both regular for his heart rate. Okay, next I'm going to have the patient lie down to look at his jugular venous pressure. I'll do some of my stuff. You can lie down, and I'm going to try to get the patient for his head to be at 30 degrees for this. Okay, so for the JVP, or jugular venous pressure, you are looking at the patient's right internal jugular vein and seeing the pulsation, which I can see. And my patient's a healthy 25-year-old male. However, if he did have some indication of cardiac disease, you would perform this in your clinic. And you would take your ruler using the centimeter side and line it up with the sternal angle. And then you take another flat paper or what have you and just measure from the pulsation. And anything more than 3 centimeters would warrant further attention. It was less than 3, so this is normal. Okay, and then at this time, we're going to move down the front of the chest. Male or female, you would inspect the breast, looking at the skin, the nipples, the areola. Everything should be symmetric. There shouldn't be any drainage. You want to palpate for lumps or masses, and anything that you find would obviously warrant further attention. So next we're going to move to the patient's abdomen. I'm just going to lift up your shirt, Andrew. You want to be able to visualize the whole abdomen. And we're going to look first. So I can see that the patient's abdomen is flat as far as the contour, non-distended. I can see the pulsation of his aorta, which is normal for a thin, healthy individual. I'm looking at his skin. He is warm, dry, intact. No lesions or scars or striae. A small amount of hair, which is a normal finding for a male. And with the abdomen, we want to auscultate before we percuss and palpate. So I will do that next. In all four quadrants. So right upper. Excuse me, left upper. Left lower. Right lower. And right upper. So you're listening for those gurgle vowel sounds, and he's got active vowel sounds in all four quadrants. Also, we can test for the umbilical reflux right now. Just watching for that little reflex to appear by the umbilicus. And then we can also auscultate for bruits. Once again, he's healthy, but in somebody who's not as healthy, you might be able to hear a bruit. So we're going to listen for the aortic. Renal. Iliac. And femoral. So I'm unable to hear any bruits on him. Just a normal finding. Next we're going to percuss the abdomen and noting any areas that sound abnormal. The abdomen should be tympanic and should have dullness only over the liver and the spleen. So I'm going to start up here. And then over the spleen. So, as expected, tympanic sounds heard throughout, except over his liver and his spleen, which are dull. Okay. And then we can do light and deep palpation. So first, I'm going to do light palpation, noting any masses or tenderness that the patient might complain about. And then we're going to do deep palpation, going down a little bit further. Also palpating over the bladder for any distension or tenderness. And then we're going to palpate for the liver border and for the spleen. Since I'm on this side, I can go ahead and do the spleen. And you want to ask the patient to try and turn towards the right a little bit. Towards the right. That's good. Okay. So for this, you're going to put one hand behind. And I'm unable to palpate his spleen, which is completely normal. We just do not want to be able to palpate the spleen, which would indicate splenomegaly. And then we're going to palpate for the liver. So we're going to find ribs here, mid-clavicular line. You're going to ask the patient to put one hand behind his support and ask the patient to take a deep breath in. And then push down, out, in. And you should be able to palpate the border of the liver. And the patient shouldn't have any tenderness, but if they did, you would note that. And then next, you want to palpate for the aorta. So I'm able to see the pulsation, but I'm just going to press down at the midline here. And I can feel the aorta and its pulsation, and it feels less than 3 centimeters, which is normal. Now we're going to move down to the inguinal area and the lower extremities. So this time, once again, I'm inspecting the skin, looking at his groin, his lower extremities. Skin, once again, warm, dry, pink. No lesions, abnormalities, hair evenly distributed. I don't see any gross deformities or abnormalities. No varicose veins. So in these areas, you're looking at a couple different systems. You're looking at peripheral vascular as well as musculoskeletal. I can check his nails at this time for cap refill. Less than 3 seconds. Less than 3 seconds. Very good. Also, I can check for pulses. So we're going to start proximal to distal. So we'll do femoral. Okay, and then we're going to do popliteal behind the knee. We can do posterior tibial, and then dorsalis pedis. And all of his pulses are +2 and palpable, normal finding. Also this time we're going to palpate his joints for any tenderness, the tenderness in your hips, your knees, your ankles, and your feet.
Yeah.
Okay, that's very good. And then we're going to test for range of motion of each joint. Okay, so starting with your hip. For flexion of your hip, can you bend your knee to your chest, pulling it towards your abdomen? Okay. Now can you move your lower leg away from the midline, down over the side of the table? Very good. And move your lower leg away from the midline, so towards the other side. Okay. And then bend your knee and turn your lower leg and foot across the midline. So yeah, very good. And bend your knee and turn your lower leg and foot away from the midline. Very good. So he was able to flex, extend, abduct, externally and internally rotate his hip. And did you have any pain with that?
No.
Okay. And now I do that on both sides, testing for both of his hips. And next we're going to do his knees. Okay. Can you bend your knee? Can you straighten your leg? Can you swing your lower leg towards the midline? Just kind of swing your leg over. And away. Okay. So he's able to do that, showing he has full flexion, extension, internal and external rotation. And he had no pain. I didn't hear any crepitus. All normal findings. Full range of motion. And I would also do each one of those maneuvers against my resistance as well. So we can do one, for example. Let's do your knee here. So can you push against my hand? Okay, push against my hand. Okay, very good. So you would get 5 out of 5 for his muscle strength throughout as I go through each one of those to test for resistance. And then we need to do your ankle joint, foot and ankle. Okay. Can you point your foot towards the floor? And can you point your foot towards the ceiling? Can you bend your heel inward and bend your heel outward? Okay. So that's showing he's got full ankle flexion, ankle extension, inversion, and eversion of his ankle and foot. Then can you just point your toes up and just point them down? Okay. So no crepitus once again. He was able to follow my commands and show that he's got full range of motion of his feet and ankles. Okay, lastly we're going to finish with neurologic. So Andrew, you can sit up again. Towards the camera, please. throughout the exam, I've been observing him, I've been assessing his neurologic status. He is alert, he's oriented, he follows my commands. I already tested most of his cranial nerves with my head, face, eyes, ears, nose, throat, neck exam. So most of the neurologic exam is already done. Sensory, I already tested for the dull and sharp sensations. I could have done the vibratory sensation with the tuning fork, but I forwent that test for lack of a tuning fork. So lastly, we're just going to do your fine motor skills. We did the position sensory test with his thumb telling me he felt the up and the down sensation. So now, Andrew, can I have you touch your nose with your alternating index fingers with your eyes shut, so like this. And just do that a few times for me. Okay, so he's able to successfully do that. Now we're going to rapidly alternate our fingers and thumbs. Very good. And I want you to rapidly move your index finger between your own nose and my finger. Okay. And then lastly, can you just go like this with your hands real fast? Okay. Okay, so he passed all those tests, showing his fine motor sensation is intact. Andrew, with your lower extremities now, can I have you run your heels down each one of your legs with the tibia? He's able to do that. Also, I can test his deep tendon reflexes. So the brachioradialis, do that first. Just try and relax your body like a rag doll. Next we'll do the tricep. Just relax your arm. I'm going to hold it and support it here. Relax. Okay, then we're going to do your radial. Okay, and then your patellar. And then your Achilles. Relax you. Okay. So all his deep tendon reflexes appear to be intact. Next I'm going to observe the patient's gait since I did not see him walk yet. So Andrew, if you can stand up for me. And I'm going to have you walk heel to toe for a few steps. I'll tell you when to stop, okay? So you can just walk heel to toe. Okay, and turn around. So his gait is steady, his balance is coordinated, he's not swaying or falling over. Okay, Andrew, and then can you do the same thing, walking on your heels? And then walking back on your toes. So walking on your heels, very good. And then walking back on your toes. Very good. So he is able to perform those maneuvers. And then we're going to do the Romberg test. I'm going to have you stand straight in front of me, and you want to stand close to the patient in case they fall over or sway. And you're just going to have them close their eyes, put their arms by their side, and as a practitioner, you're going to count for 30 to 60 seconds, and you're just watching for the patient's balance, watching if they're swaying at all, or deviating from the midline of standing straight up. So I would count 60 seconds. He's not having any swaying. Perfect. So he passes the Romberg test. If I had any sort of inkling or observation that he was neurologically impaired, I could further test his mental status with a cognition, a mini mental exam, testing short-term and long-term memory. But he has interacted with me appropriately. I have no suspicions of any mental status changes, so don't need to do that. And now we're just going to check your spine now that you're standing up, so if you can put your back towards me. And I'm just looking at the contour of your back and at your shoulders specifically as you do this maneuver, and your scapula. So can you bend at your hips here for me? Try and touch your toes. So I'm looking at his shoulders, looking for any signs of like scoliosis or abnormal curvature of his back. And Andrew, can you bend back for me now? Come back towards me, extend back your back, and then forward. And his shoulders are equal on both sides. I didn't see any deviation from that. And Andrew, you can sit down for me. So that concludes our physical exam. If this were in a real setting, you would proceed with the anorectal and genitalia exam. For him, it would be his penis, scrotum, testes. You'd be feeling for any lumps. You might transilluminate the scrotum, looking for any fluid, masses. You'd be examining the skin, once again, noting any lesions or anything that stands out at you. And then the very last thing you would do on a male is the anorectal exam. For him, checking the prostate, most specifically for any edema or tenderness, and noting your findings. So that concludes our exam for today. Andrew, thank you very much.
Thank you.
All right.